Good evening, one and all. Welcome to the CCI's today's webinar. Today's webinar we are having related to acute shortness of breath, and we are having the multiple faculties from all over the countries, all the corners, from the different specialties. Actually, Dr. Amita Nene is going to moderate this session as with some technical reasons she will be late. That's why we are starting the show. She will join us soon. We are having the physician side from Dr. Sumit Wadhwa. He's a senior physician consultant from the Gurugram, and he's additionally a chest physician also, and he's a dual the specialty person, physician plus pulmonologist from Delhi. Welcome, sir. We are having Dr. Ankit Mittal. He's a cardiologist. He's one of the few persons in country having the pulmonology and cardiology both backgrounds. Welcome, Dr. Ankit Mittal. And we are having the psychiatrist, Dr. Virinchi Sharma from the Hyderabad. Welcome, Dr. Virinchi Sharma. And from the endocrinology, we have the Dr. Abhamoni Agarwal from the Guwahati. I welcome all the panelists to discuss this seminar related to the shortness of breath. And first, we'll start with Dr. Sumit Wadhwa, sir. And we'll go ahead with the what is the basics of the breathlessness, what are the causes, how to manage all those things, how to approach the case. So first we'll go with Dr. Sumit Wadhwa sir's presentation. Over to Dr. Sumit Wadhwa, sir.
Hello everyone. At the outset, I would like to thank the Chess Council of India for giving me this opportunity, and I would also like to express my gratitude to Dr. Amita Nene for kind words of introduction. So, I am Dr. Sumit Wadhwa, and I'm a consultant internal and pulmonary medicine in Gurugram. So the topic for today is approach to a patient with dyspnea. I'll be sharing some brief highlights with this. So dyspnea is an abnormal sensation of breathlessness or inadequate breathing, and it is one of the common complaints the patients have with cardiopulmonary disease. And patient may also complain of shortness of breath, uncomfortable breathing. A dyspnea of exertion is mainly patients have shortness of breath mainly on exercise. It is primarily an indication of inadequate ventilation or insufficient amount of oxygen in your blood. Now, in approach to a patient with acute dyspnea, when he may complain of poor inspiration, tightness of the chest, sensation of breathlessness or air hunger, or incomplete exhalation of the chest, the first thing is to quickly stabilize the patient and manage his airway, breathing, and circulation before going on to the further management. The pathophysiology I will briefly discuss is dyspnea when there is a mismatch between the efferent and the efferent signals to the brain. The brain receives the signals from various receptors in our lungs and our vascular system, and this information is further processed, and efferent signals are then sent through the motor pathways. And if there is the level of respiration is inappropriate for the body's status and need, then one may perceive as having dyspnea. The types of dyspnea, we may have orthopnea, that is dyspnea on lying down flat or supine, and this is common in patients with left ventricular impairment or heart failure. Then one may have platypnea, that is breathlessness, which is more on sitting position and gets better when one lie down, and this is seen in patients with right to left shunts. Then one may have tropopnea, that is breathlessness, which is more in lying in one lateral position, which may have been there in unilateral lung disease, and the patient usually prefers to lie on the healthy side. The common causes of acute dyspnea may be systemic involvements involving heart disease, lungs disease, sometimes both cardiac and pulmonary, or a non-cardiac or non-pulmonary cause may be there. Prominent causes among heart disease include a congestive cardiac failure, an acute MI, arrhythmias, or cardiomyopathy. Among pulmonary causes, we may have asthma, COPD, acute exacerbation, a pneumothorax. With both systems involved, we may have COPD with pulmonary hypertension or chronic pulmonary emboli. Among non-cardiac causes, we may have sepsis-related metabolic acidosis or any poisonings, any pain in chest wall, localized chest wall diseases, any anxiety disorders, and neurovascular disorders. The first thing after stabilization is the history of the patient, and in the history one must ask for the onset of disease, how soon it has occurred, and this may lead acute causes within minutes may be present in lung disorders such as acute exacerbation of asthma, pneumothorax, pulmonary embolism, any foreign body aspiration. Among common cardiac causes, we may have acute myocardial infarction and heart failure. Then the onset and course, we may also look for any subacute causes which may have been beginning within days or weeks. So we have pneumonia, heart failure, asthma, pleural effusion should be kept in as differentials. The timing of dyspnea is also important. Patients with asthma may have nocturnal symptoms early in the morning or after midnight. Similarly, patients with heart disease and congestive cardiac failure may also present with paroxysmal nocturnal dyspnea, in which the patient wakes up with breathlessness and has to sit up or stand to get better. And you should also look to the severity of dyspnea. So we may have two scales like the MRC scale in patients with COPD and lung disorders, and NYHA scale for patients with congestive heart failure. In class 4 patients with NYHA, we may have dyspnea or angina even at rest. Should also look out for any precipitating or relieving factors such as exercise, exposure to cigarettes or allergens, any occupational exposure. Similarly, the number of medications which the patient is taking and which medications give his relief, and what are other relieving factors like rest, which relieves his dyspnea. Should also ask for the associated symptoms besides shortness of breath, like any chest pain, any wheezing, fever, which may indicate infection, any cough with purulent sputum indicates pneumonia, any change in the voice or laryngeal edema, any hemoptysis, which indicates chest infection or tuberculosis, heartburn, vomiting or diarrhea may indicate something related to the stomach. Then should also take into account the past medical history of the patient, including of any cardiac or pulmonary diseases, any drug history, smoking history, or occupational history. On examination, should look for any wheezings, accessory muscle use, especially in patients with acute exacerbation of asthma or COPD, any fever, crackles, or increased vocal fremitus seen in patients with pneumonia, pedal edema with engorged jugular veins, then S3 or S4 gallop with murmurs indicates congestive heart failure or pulmonary edema. Absent breath sounds on one side may indicate a pneumothorax, then stridor with drooling and wheezing may also rule out epiglottitis or any foreign body aspiration. So these are the common list of disorders according to the organ involvement in which the patient may present with acute dyspnea. These may have asthma, COPD, acute coronary syndrome, any rib fractures after chest trauma, anemia, metabolic acidosis, and thyrotoxicosis are other systemic causes, and psychogenic causes include anxiety and panic attacks. So common investigations should be started after stabilizing the patient, which includes a complete blood count, the liver and kidney function test, an arterial blood gas, a sputum examination if the patient is having purulent sputum, then routine electrolytes and kidney function tests. Should also take a bedside chest X-ray and ECG for assessing the cardiac and pulmonary status, and involve a point of care echo and ultrasound done, and D-dimer if the patient we have a high suspicion of having a pulmonary embolism. Now, coming to the briefly around the general management, the primary goals is to optimize the arterial oxygenation as soon as we see the patient, and to assess if there is need for any emergency airway management or ventilatory support, identify any life-threatening illness like acute coronary syndrome, heart failure, tamponade, any exacerbation of COPD of asthma, any poisoning or trauma. And you have to identify the signs of any imminent respiratory arrest like depressed or altered mental status, poor inspiratory effort or agonal breaths, cyanosis. These may indicate imminent respiratory arrest, and one may arrange for ventilation as soon as possible. And signs of respiratory distress including chest retractions, fragmented speech, respiratory rate more than 25 per minute, orthopnea, profound sweating, audible stridor or wheezing. These are signs of immediate respiratory distress and should be taken care of as soon as possible. General measures include providing oxygen supplementation to maintain oxygen levels at least more than 94%, establishing an IV access, obtaining blood for all lab measurements, should include continuous cardiac and pulse oximetry monitoring. Airway management should be kept, equipment should be kept standby, and you have to determine the need for airway management and ventilatory support, obtain bedside ECG and chest X-ray, and arrange for point of care echo and ultrasound. So the management strategies in general include to reduce the ventilatory demand, decrease the sense of effort for the patient, improve the respiratory muscle function, and support the lungs and pulmonary rehabilitation after recovery. Thanks for your patient support. I would now like to hand it over back to Dr. Amita Nene for carrying the discussion forward. Thank you.
Amita Nene, ma'am. Actually, I have introduced the speakers, and already Dr. Sumit Wadhwa has presented his presentation. Now you can carry forward with your questions. Over to Amita Nene, ma'am.
Hi, everybody.
Good evening, ma'am.
Good evening. Dear Dr. Wadhwa, that was such a fantastic talk. I mean, Dr. Sumit, it was wonderful. Absolutely a crisp talk, which gave us all the possible information, right from what is acute shortness of breath to what causes it, and what are the mechanisms, and how to diagnose it, and how to manage the patient. I feel that this was absolutely a state-of-the-art talk, and thank you so much. So I'm very so huge big congratulations to Team CCI once again, Dr. Krishna, Dr. Atri, Dr. Vijay Kumar Chenam Chetty, Dr. Ravi Dosi, Dr. Narendra for conceptualizing something so fantastic, which is going to be extremely useful to us in our day-to-day practice. And luckily for us, we have a huge panorama of amazingly qualified, amazingly brilliant, amazingly distinguished panelists who are going to be with us from every possible field to help us actually solve this really big saga of a patient presenting with acute shortness of breath. So before we start the panel discussion, I have the huge honor of introducing all the lovely colleagues of mine who are themselves huge and great achievers. So Dr. Sumit Wadhwa already gave us a talk. He actually requires absolutely no introduction. I'm just doing the formalities. So Dr. Sumit Wadhwa, he is a consultant practitioner at Global Health Experts, Gurugram, Haryana. And we know such great work he does, and we also know what a great teacher he is. So welcome Dr. Sumit Wadhwa to the panel discussion. After this, I have a dear colleague of mine, Dr. Chandrakant Tarke, my dear colleague, who is also in Maharashtra, who is also in Hyderabad. Though he's in Hyderabad, I still feel he's in Maharashtra because he's so close to our heart. So he's not only MD, he's also a DM. And basically, he is a consultant in Hyderabad, and he's attached to the Apollo hospitals. So welcome, and I'm sure you're going to give us such major information in solving this problem out. Then I have a lovely lady with me, Dr. Abhamoni Agarwal, who's a very renowned and very, very efficient endocrinologist, and she's a consultant endocrinologist at Pratiksha Hospital, Guwahati. So welcome, Dr. Abhamoni. We look forward to your contributions. Then we have a very young and dashing psychiatrist with us, Dr. Virinchi Sharma. He is going to really make the discussion, I think, extremely interesting because I'm sure he's going to have very interesting inputs to give us. So he is basically at Manasa Hospital, Hyderabad. And last not the least, we have Dr. Ankit Mittal with us. He's a cardiologist. And he's going to be giving us a lot of information because his outlook is going to be a little different from us pulmonologists. So he has done his DM cardiology and he is at Delhi at the Bansal Global Hospital. So a warm welcome to all the fantastic panelists, and let's start our discussion. I'm sure it's going to be very, very useful to everybody. So the first question, let me just think who to start with. So maybe let's start with Dr. Chandrakant Tarke. Dr. Tarke, hi. So though Dr. Sumit Wadhwa has covered everything, I'm sure it'll be good to have little revisions. So can you please tell me what is the definition of shortness of breath? And after that, part 2, please tell us the pathophysiology and mechanism of shortness of breath, including the receptors involved.
Okay, ma'am. Actually, shortness of breath is a medical term, is a dyspnea, and it's an uncomfortable, abnormal awareness of the breathing. These three terms are important. Uncomfortable, that is not comfortable. It's abnormal, definitely it's not normal. And awareness of the breathing. Normally, we will not aware of our breathing unless we are not aware. Okay. And it's perceived as increased respiratory work or effort or chest tightness or air hunger. And different people, different patient can have the different breathing perceiveness. Some patient can have the difficult to take the air in, some patient can have the difficult to take air out, some patient can have the chest tightness. Basically, it's uncomfort awareness of the breathing. That is the definition of the dyspnea. Coming to the pathophysiology of the dyspnea is very complex. And it involves the chemoreceptors, that is the central and peripheral. Plus, it involves the receptors in the lungs and airways. We have the central chemoreceptors such as in the medulla, brain, and we have the peripheral chemoreceptors such as in the carotid body or the aortic chemoreceptors, which supply the information regarding the oxygenation, carbon dioxide, and hydrogen ions. And they sense the basically acid-base balance in the body, and they supply information to the central processing unit, that is the central nervous system. There the information will be processed, and the efferent information will be given through the respiratory muscles via the different pathways such as vagus nerve. And whenever there is an imbalance between the afferent and efferent signaling, then there will be the patient can feel the breathing difficulty. That's why this and the efferent signaling will be by the mainly it goes to the diaphragm, which is the most important muscle of the inspiration. That's why basically the pathophysiology involves the three components of the system. One is the afferent signaling, one is the efferent signaling, and one the central information processing. And whenever there is the imbalance between these two, mismatch between this need of ventilation, that is afferent signaling, and which is not being met by the physical breathing, that is the efferent signaling, then we can have the dyspnea.
Absolutely. So this was absolutely in detail. So all the people who are exam goers, they will be extremely happy because they exactly know how the mechanism of breathlessness works. So basically, if you are aware that you are breathing, then we call it breathlessness because you're not supposed to be aware of your breathing. So in short, if the patient thinks that I'm aware of my breathing, we will call it breathlessness. This was a very, very great answer given by Dr. Tarke. Now, let me go to Dr. Virinchi. Dr. Virinchi, this is what we pulmonologists feel, what breathlessness is all about. From a psychiatrist point of view, can you please tell us, according to you all, what is the neurobiology of sleep?
Very good evening, one and all, and thank you so much for the wonderful introduction, Dr. Nene. Coming to the question specific, when we talk about the neurobiology of anxiety or breathlessness, I think we all know the HPA axis, the hyperactivity of the HPA, where there is excess cortisol, and we all know how cortisol has bad effects when it's at higher levels. We know that cortisol has a bad effect on the entire system, starting from hair to the toenail. But what happens above the hypothalamus is something which talks more about the neurobiology of anxiety. And right above the hypothalamus, we have two more important centers. One, the amygdala. So the amygdala is the one that detects something that is scary. So I'm walking on a road and suddenly I see two people trying to attack me. That is my amygdala getting activated. Or I'm walking on a road and I see an animal, in my foresight, my amygdala gets activated. But not necessarily that every time there is some situation, amygdala gets activated and there is a lot of things happening, because on the other side there is the prefrontal cortex which tries to tell that okay, you don't need to worry. So we have amygdala telling us get scared, we have the prefrontal cortex telling us don't get scared, and a lot of chemical changes that happen which does not allow the prefrontal cortex to take the right decision. Because if you all go back to the central nervous system, the brain, prefrontal cortex plays a very important role in decision making, and also it plays an important role in extinction of fear. So now when this prefrontal cortex is not able to do its best of the activities, and when then there is reduced GABA, which is the inhibitory neurotransmitter, that is when the amygdala sends signals to the HPA axis and the whole increased cortisol levels happen. So if you ask me, in short, it is the hyperactivity of amygdala and the hypoactivity of the prefrontal cortex which leads into the anxiety.
Wonderful. So this is great. This is really a great answer, because we pulmonologists can't just look beyond our diaphragm and the afferents and the efferents. So now I'd like to go to Dr. Sumit Wadhwa. So the thing is, you've already very nicely told us, but I'm going to ask you once again for the benefit of those who probably could not join the meeting in time. So can you please tell us what is acute breathlessness and chronic breathlessness, the difference between the two? And also, what are the causes of acute breathlessness and causes of chronic breathlessness?
Good evening, ma'am, and thank you all. So acute breathlessness is one which occurs in minutes to hours, and the patient mainly may have primarily respiratory or cardiac causes, and these are mostly life-threatening causes. We have to be excluded basically. So the patient may have an acute exacerbation of asthma, embolism, or a foreign body aspiration, or laryngeal edema. He may also have a chest pain with decreased breath sounds suggesting a pneumothorax. On the cardiac side, other side, he may have acute myocardial infarction or congestive heart failure, or acute aortic dissection. So chronic cause are which the patient has been having since long time, and they have suddenly resurfaced now. So like his patients having chronic obstructive pulmonary disease, having acute exacerbation, or patients with congestive heart failure presenting with grade 3 and grade 4 dyspnea on NOI check. Last, third would be subacute causes which may have presented in weeks. So this may include pleural effusions or pneumonias or persistence of asthma symptoms.
Perfect. I think that was a great answer. You want to say more? Yeah, I think this was really very, very comprehensive. Exactly. It was really good. Acute is something which is over minutes to hours, and chronic is something which is over days to weeks. And you also told us the causes. So thank you very much. Now I'd like to come to Dr. Ankit Mittal. So, actually the thing is that whenever we get a 2D echo done, we as pulmonologists always want to look at what is the ejection fraction. We look at basically the pulmonary artery pressures. We don't normally look at diastolic dysfunction, and of course we know it is important. So can you please let us know what is the role of diastolic dysfunction in dyspnea?
Good evening, ma'am. Thank you for the introduction. Ma'am, so diastole, as you know, is the part of the cardiac cycle where actually the relaxation is occurring. This is the part when LV is actually filled for the ejection ultimately. We always think that diastole is a passive part. It is actually an active process requiring ATP. So it is not only a passive process. So whenever we are dealing with a patient with infarction or ischemia in such patients, it is not only the systolic function that is affected, it is also the active relaxation which is affected. So it leads to poor LV compliance. And also in other conditions like LVH, accelerated hypertension, cardiomyopathy, these all conditions leads to increased stiffness, and that leads to increase in decreased LV filling, leading to diastolic dysfunction. If LV is not properly filled, the LV pressure will actually increase. The increased pressure of the LV will be transmitted to the LA, which will be transmitted to the pulmonary vein, and leading to increase in hydrostatic pressure, leading to pulmonary edema that we all know. But again, as you just said, there is a tendency to ask for PA pressure And ejection fraction, whenever we go for echo in ICU or in critical care setting, we ask we deal with patient pulmonary edema. If I do an echo and I say the ejection fraction is normal, the person will ask me, oh, the patient is in pulmonary edema, and you are saying that no, it's having a normal ejection fraction. So actually, they are not bothering about the. They are not actually considering pulmonary diastolic function at that time, and which is very important, has a significant role to play. We always should ask for diastolic function, and all the echos we are doing, we should always look for diastolic dysfunction. That we can easily do with the echo. We just have to take two parameters to diagnose the diastolic dysfunction in a patient, and that's it.
Okay. No, so thank you so much. I think this is a very important point which I want everybody to take note of. Because the thing is that whenever an echo is done, even if your cardiologist has not mentioned about diastolic dysfunction, please don't allow that to happen. Please, in your echo, you write ejection fraction, pulmonary artery pressures, functioning of valves, and diastolic dysfunction, and make sure it is mentioned, because very often that could be the cause of breathlessness which is being missed out. Yes, Dr. Ankit, please tell us.
Ma'am, it is not only the diastolic dysfunction, also we can also measure the LV-EDP in the echo. That is the pulmonary venous pressure.
Absolutely, very well said. But what I want to actually press upon is that in addition to ejection fraction, in addition to valves, in addition to pulmonary hypertension, very often the diastolic dysfunction could be present. And please look for it, please ask for it, and a big dilemma might just get solved. Now I'd like to come to Dr. Abhamoni. She's been quietly smiling at us, and I'm sure she's going to give us something very interesting for our knowledge. So we always feel if a patient is breathless, then either the patient is a lung patient or is a heart patient, or if it's a girl, we think she's anxious, she's panicking. So are there any endocrinal causes of breathlessness that we need to think about?
Yes, a lot many. So if with your permission, can I share my slides, madam?
Actually, it'll be better if we can just talk about the things that'll be more fun.
Okay, so there are not many endocrine causes that would actually come with acute shortness of breathing. So most commonly in diabetic patient, now like India has become the capital of diabetes, and so many millions of people living with diabetes is present. So in diabetic patients, we get breathlessness because of diabetic ketoacidosis, then hyperosmolar coma, then we can get breathlessness because of metabolic acidosis. We get breathlessness in diabetes because of other causes like pulmonary edema and cardiac failure and pulmonary embolism as well. So this is about diabetes. Even in hypoglycemia, sometimes if with a severe hypoglycemia, patient do complain of acute shortness of breathing. So both hyperglycemia and hypoglycemia would present with shortness of breathing. So apart from them, one important cause is hypothyroidism. So even in myxedema coma, if the patient is untreated, long-standing hypothyroidism can present with respiratory failure. And again, the most common cause of death in myxedema coma is respiratory failure. So apart from this, even hyperthyroidism and other causes of hypercoagulable states like Cushing's syndrome and all. So in these cases, they are also at risk of pulmonary embolism. So they can present with acute shortness of breathing. Apart from that, I want to mention one important cause is stridor, that is laryngospasm. So many patients, they undergo thyroidectomy for papillary thyroid carcinoma, any malignancy in the thyroid, or maybe Graves' disease. So these patients, we have to always monitor them very closely after operation, because of hypocalcemia, because of iatrogenic post-operative hypoparathyroidism, they can go into laryngospasm, and then they can present with severe dyspnea and may require mechanical ventilation as well. Apart from this, there are hypokalemia, they can have respiratory failure. There are many other causes like pheochromocytoma, which lead to cardiac abnormalities, and finally, they can precipitate as acute shortness of breathing.
This was absolutely fantastic, Dr. Abhamoni. I've learned just so much from your answer. So just to rapidly, I'm just trying to, repeat it. So basically, the thing is that whenever there's metabolic acidosis, whether it's because of diabetic ketoacidosis, whether it's because of lactic acidosis, whatever may be the cause, we know compensation is by respiratory alkalosis, and therefore the patient is going to hyperventilate, and therefore the patient is going to be aware about of his breathing, and therefore this patient is going to come to us complaining of breathlessness. So metabolic acidosis is a very important cause of breathlessness. We always have to think about this. Another second point I really liked about was hypocalcemia, because hypocalcemia is known to cause laryngospasm, and a patient can actually present with upper airway obstruction in the casualty, and this could really be disastrous. So I basically feel that this is also a very, very important point. Pheochromocytoma, not very common, but we have to keep it in mind. Myxedema, the patients will actually probably even come in type 2 respiratory failure. More than patients saying not breathing or uncomfortable, the relatives could be saying that the patient is not actually breathing. But what is really important is that certain electrolytes, potassium, magnesium, calcium are very, very important. So if you have hypermagnesemia, you have hypokalemia, you have hypocalcemia, these can actually give rise to breathlessness, and hypercalcemia can also give rise to breathlessness. So just to say that there was this lady, she was a lawyer, she felt breathless all the time. She had seen 4 chest physicians, every possible test was done, everything was normal, and then she was told that probably you're anxious, probably you're worried, just take a holiday, don't work so hard in the high court. She came to me, her calcium was actually high. And it was high only because the patient was really not drinking enough water. We ruled out other causes of hypercalcemia, and just correcting her calcium took her breathlessness away. Because she was a lawyer, she was planning to actually want to sue the other 4 chest physicians who missed it. But of course, we discouraged her and we made sure that didn't happen. But calcium, potassium, magnesium are extremely important. Thyroid is very, very important. Or even whether there is acidosis or not is very, very important. Bicarb, pH, please look for these things before you decide that the breathlessness is not real. So thank you, Dr. Abhamoni. With this, I go to the second round of questions to all our panelists. And now in between, we are also going to ask them to verbally give us some anecdotal case examples like Dr. Abhamoni did. So now I'd like to come to Dr. Chandrakant Tarke. So Dr. Tarke, please tell me, what is the importance of history taking while you're evaluating a patient who presents with breathlessness?
History taking is the most important part of the patient's evaluation. Especially for the breathlessness, we can come to some etiology, means we can find out what is the exact problem with the minimal investigations. That's why with the history, if we have the good history taking, we can find out the diagnosis also. We can find out the system involved first, whether it's a cardiac origin, respiratory origin, or metabolic or psychological with the history taking. First, we have to come with the age. If the age is children's, they are prone for the foreign body inhalation, they are prone for the bronchiolitis. If some younger persons, they are prone for the asthma attacks. If you go further, then elderly, some young ladies, they can have the connective tissue disorders. If you go further, then elderly males, they can have the interstitial lung disease, COPD. With age-wise, we can come to some narrow down the differentials. With the gender-wise also, for example, young ladies, some like with the anxieties, psychological things. With the elderly people, IPA, with the age, gender, we can come to some conclusions related to the narrow down the differentials. And with the history of the risk factors such as smoking, we can have the COPD, smoking-related ILDs, smoking-related other diseases, occupational exposures. We have to take the history of some travel to some place, travel to some hilly areas. They can have the acute pulmonary edema. We can take the history of allergy in the family. These people can have the urticaria, asthma. Asthma can cause a breathlessness. We can take the history of this thing also, foreign body aspiration, and symptoms such as particular, for example, a cardiac patient can have the apnea, paroxysmal dyspnea, palpitation. If there is a short onset pain, we can come to the conclusion of pneumothorax or aortic aneurysm rupture. These are the few points, especially in the starting from age, gender, and the important basic this clinical symptoms, whether it's acute onset, short onset, and the exposures. Combining all these things, we can come to some conclusion. We can narrow down our differentials, and we can do the minimal basic test to come to some diagnosis.
Fantastic. This was very, very comprehensive. Do you want to say something more? I'm sorry if I interrupted you. Yeah, so Dr. Tarke, thank you. You just told us everything. History taking is very, very important, because it will tell you, first of all, which system is being involved, and it will also take you towards the diagnosis. And then with minimum investigations, you can actually pinpoint, even in a casualty where patient could be really hypoxic, you exactly know what needs to be done. After this, I'd like to come to Dr. Virinchi. Dr. Virinchi, are you there? Hi. Yes. So, I really like psychiatry. I feel that if I didn't become a pulmonologist, I would like to become a psychiatrist. And they have this very fantastic angle, which we don't end up really looking at, So I have this question for you. Are psychogenic causes of shortness of breath underdiagnosed? Number one. And part two, what is the fate of such untreated psychiatric conditions?
Well, ma'am, I think, if you ask me about the underdiagnosis, at least I would say that half of the patients who come with psychogenic causes of shortness of breath to me are referred to me by my physician seniors and colleagues. But somewhere, if you look into the statistical data, a lot of studies give us some interesting numbers. There is a study in 2015 and 16 which spoke about almost 8 to 10% of people presenting to physicians with shortness of breath have a psychological cause and not a medical cause. And then if you look into some more studies which talk about people with COPD and asthma, they say that studies say that an individual, a patient having COPD or asthma, if you look into 100 people, 50% of them do have an underlying anxiety or depression, probably which started before the COPD or after the COPD. Now, I think this is a big question to all of us, because are we able to identify these numbers? The reason why I'm saying this is we're all very busy practitioners. And once we are, limiting ourselves to a particular field, yes, it's difficult to always think beyond it. I'm not saying we do not know it, but we are so used to. So the first time when somebody comes to me with shortness of breath, I'm going to look at anxiety. I'm never going to look at asthma, which is probably more common. So that way, if you look into these numbers, this is something which is alarming. And a lot of times, by the time the individual comes to us, it's a little late, because, they've been having these symptoms repeatedly. They've been going to the ER repeatedly. They've been told that, okay, everything is fine. You're just taking some stress. Again, the reason why this is being told to them is there's a very thin line between anxiety and anxiety disorders. So all of us get anxious at one point, but we do not know if it is at a disorder level. So somewhere, I think because of multiple factors like these, I feel, yes, the psychogenic causes of shortness of breath are underdiagnosed. And undoubtedly, the delay that happens in the onset of the treatment or this underdiagnosis surely plays a very important role, because it has very bad effects on the individual's quality of life, on the individual's self-esteem, and as well as these untreated anxieties do convert into depressions a lot of times. And once somebody falls into the category of depression, the highest risk of suicides in psychological or in medical conditions is in depressions, like we all know. So I think that one diagnosis can save a lot of things that can happen.
Okay, that was really good. And to think that 10% of people who present to casualty as breathlessness might be having psychogenic causes is extremely important information. Later, we're going to ask you also how to manage them, because we manage them our way, but I'm sure you're going to contribute a little more. I'd like to again come to Dr. Abhamoni. So, Dr. Abhamoni, I really liked your answer. And I kind of feel that though you told us things about what are the endocrine causes of breathlessness, I want you to again expand on the same, because you gave us so much of information. Probably we've not digested everything. So if you could just, either you can give us an example of any of your patients, telling us about how endocrine cause of breathlessness can present in a casualty.
Yes. So, I would just want to tell the physicians in the audience that how to approach a patient of acute breathlessness who have come to your OPD or the casualty. So, suppose a patient with acute breathlessness, he comes to your casualty, then you have to take a thorough history and physical examination. So, in the history, always first ask whether you have diabetes. So if he has diabetes, so blood, immediately check blood sugar. So it could be both hyperglycemia or it could be hypoglycemia. So then you ask whether the patient has hypertension. So hypertension, again, very uncontrolled hypertension. It could be associated with any failure, or uncontrolled hypertension could be associated with adrenal disorders like pheochromocytoma, hyperaldosteronism, adrenal tumors, Cushing syndrome. So all these things. Then you ask whether it's or hyperthyroidism. So again, hypothyroidism will be associated with weight gain, lethargy, constipation. However, in contrast to that, hyperthyroidism patients will have palpitation, tremors, and then hyperdefecation and weight loss. So accordingly, we can judge what the patient fits into. Then come to the examination. So in the examination, again, pulse is very, very important. Patient with hyperthyroidism, with hypoglycemia, hyperglycemia, diabetic ketoacidosis, everybody is going to have tachycardia. So again, after that, you have to check the thyroid goiter. So if the patient has goiter, just look at the patient. If the patient is looking anxious, very there is some eye signs like proptosis, exophthalmos there, patient is flushed, and then you get so much of tachycardia, a big goiter, then definitely think about hyperthyroidism. Then the patient can also have hypothyroidism. You'll have all the myxedematous features, like nobody will fail to diagnose a hypothyroidism with the typical features of myxedematous edema, pedal edema, non-pitting pedal edema. So all these things you have to take into consideration. Also, there are some telltale signs, like in Cushing's, you will see stria, like easy bruisability, very big stria, pinkish purplish stria, and that typical buffalo ham, that centripetal obesity. So that will tell you about the patient has Cushing's syndrome. Then after that, you have to see whether the patient is short. If the patient is short, and then a young girl short, patient does not have any secondary sexual characteristics, or the patient have amenorrhea, patient has not attained menarche, it can be because of rupture of coarctation of aorta as well. Then you have to see for Bostic sign, Trocheus sign. These are all signs of hypocalcemia. So patient can come with autoimmune idiopathic hypoparathyroidism also. And as madam has said, even hypercalcemia can present with breathlessness, because hypercalcemia, hyperparathyroidism is a known cause of pulmonary fibrosis. So this is a complication. And apart from it, there are definitely hypokalemic features. You have to see the patient will have all muscle weakness, proximal muscle weakness. So all these have to be seen. Bony deformity you have to see for any metabolic acidosis. So patients with metabolic acidosis will have weakness, proximal muscle weakness. They can have fracture. They can have children's, definitely they can have rickety-like features. So all these things have to be taken.
Dr. Abhamoni, this is fantastic information. I want to just say one thing for pulmonologists, that whenever a patient comes to the casualty or your OPD, we always have to check the pulse oximeter saturation. In addition, please also check the sugar of the patient. I kind of feel that this was the most important point that Dr. Abhamoni made. You check the sugars are high. You know the patient could be having metabolic acidosis. You could think that this could be Kussmaul's respiration in response to that. Look for the sugars if they are low. So this is something very, very important. Thank you so much. This was fantastic, Dr. Abhamoni. I'd like to now go to Dr. Tarke. Dr. Abhamoni told us about endocrinal examination. Can you quickly, in 2 minutes, tell us about signs or examination you want to do from respiratory or cardiac point of view? In 2 minutes? Can you please unmute? Can you please unmute yourself, Dr. Tarke? We can't hear you. Okay. I think, Dr. Tarke, I think till you can just figure out your connectivity. Can I just go to Dr. Wadhwa? Dr. Sumit, can I ask you a question?
Yes, ma'am.
Yes, so as soon as Dr. Tarke is back, we'll go to him. Till then, Dr. Sumit, because there are so many questions and audience is also putting up questions galore. So Dr. Sumit, can you just tell me what are signs suggestive of severe respiratory distress and signs of imminent respiratory arrest? Quickly, in 2 to 3 minutes.
Yes, ma'am. So as soon as a patient presents to the emergency with acute shortness of breath, so the primary thing by the emergency physician is to note is if this patient requires immediate airway evaluation or management, does he require a ventilatory system. So we have to check his airway, breathing and circulation, the first thing before starting the other, and evaluation of cause for the breathlessness. So signs of immediate respiratory arrest include patient is depressed or is not talking, he has an altered mental status, he may have low oxygen hypoxia or increased carbon dioxide that may be causing it, or any altered electrolyte imbalance that may be the cause of it. Then poor inspiratory effort, he's just sighing, he has a sighing respiration or agonal breaths. And cyanosis, it means there is bluish discoloration, even central cyanosis, bluish discoloration of the lips, or peripheral cyanosis, just signs of low cardiac output and low oxygen intake in the blood. These are signs of imminent respiratory arrest and require immediate ventilation and airway management, intubation. Then patients with acute exacerbation of COPD, asthma or heart failure, these may present with respiratory distress, which also require immediate attention. These may include the use of accessory muscles of breathing. He may have chest retractions, mainly the intercostal muscles, the subcostal area, the diaphragm, and the supraclavicular area, so that even on inspiration there is retraction of these. Then he may not be able to speak in complete sentences, and he has to take a breath in between, that is fragmented speech. His respiratory rate is more than 25 per minute, and it may be difficult for the patient to lie down, so he may have more breathlessness while lying down, profound sweating, or if there is audible wheezing or stridor, which may indicate that he is having some sort of obstruction in the upper airway. That needs to be looked into immediately before further management of the patient.
Okay, this was fantastic. So, I just want to talk about a patient, a young girl. She was all dressed up. She was like in a ghagra and she was wearing major jewelry, and she was brought to our casualty. And I happened to be over there actually because I'd come to see a chest x-ray. So anyway, so this girl was brought with a noisy breathing, and the relatives said that she just finished a dance, and the auntie was so happy that she put a spring roll in her mouth, and this is actually a fact. And after 2 minutes, she just started sweating. She became breathless, and then this noisy thing came. She came to us, her nails were actually blue in color, her saturation was 70%, and she was completely in a stridor. So we asked her what was put in the mouth. It was a spring roll. This girl was an asthmatic. So Chinese food spring roll from outside would contain Ajinomoto monosodium glutamate, and she had reacted to this, and this had actually resulted in anaphylaxis, and there was laryngeal edema. So while everybody started to intubate her in the casualty, we just took adrenaline syringe and we gave her subacute injection. Of course, we were ready with everything to intubate, but within 30 seconds, her breathing started getting better. Within a minute, her sweating stopped, and within 2 minutes, she was looking much, much better. Of course, the nebulizations were going on, oxygen was going on. So I want to just basically say is that very, very important to please identify that if it's an allergy reaction resulting in laryngeal edema, very often giving an adrenaline syringe, you can give it, if it's really bad, you can give it IV, but you can also give it subcutaneous or intramuscular. And that actually turns out to be life-saving, and always please think about this. So now Dr. Chandrakant is back to us. So Dr. Chandrakant, quickly in 2 minutes, just tell us what examination points to look for in a breath patient.
Starting from the pellar we can get in the severe anemia, which can cause a breathing difficulty. Cyanosis and clubbing also we can have in the special cyanosis in the severe acute respiratory distress. And clubbing we can get this several respiratory disorders such as advanced IPF or bronchiectasis, lung abscess, which can present with the breathing difficulty. Raised JVP we can get in the cardiac CCF. Edema also we can get in the same condition. For DVT, we can see the unilateral pulmonary edema. As I said, you can hear the audible stridor, the foreign body, or some anaphylaxis we can consider. And central airway obstruction also, the patient can present the acute breathlessness. And coming to the examination, if you do the respiratory system examination with the Ronca and Krebs, you can diagnose variety of disorders, obstructive respiratory disorders. And if there's absent breath sound on one side, we can treat pneumothorax also, which can present the acute breathlessness. In cardiac examination, we can found some abnormality, especially in the valvular heart diseases. If an per abdominal examination, if there's a massive ascites, we can have the breathlessness. So abdominal examination is also equally important. Hepatojugular reflex we can get in the CCF. And CNS exams, of course, some patients with the neurological disorders such as Guillain-Barré syndrome, polio, myasthenia gravis. I had recently one case with this thing, myasthenia gravis. Actually, patient presented with the shortness of breath, slowly onset since 1 month, but suddenly since 1 week it's increased. Since last 2 days, patient was not able to solve also. But based on his history and everything, we thought we investigated everything, X-ray, everything was normal. Because of respiratory acidosis, patient was intubated. But the patient gave history of attendant, gave the history of patient was not able to solve since last 2 days. We thought of there is some bulbar involvement also, and accordingly, all the lab tests are normal. Only EBG was abnormal, X-ray was normal, only ECG, 2D, everything normal. The anticholinesterol antibodies levels were high. That's why I come to conclusion of the diagnosis of the myasthenia gravis, and this was the cause of his breathlessness. And patient improved the high dose of steroids and plasmapheresis. This is the one way we can come to some conclusions with the history and examination. And additionally, breathing patterns, certain breathing patterns, acidotic breathing, shallow breathing, pursed lip breathing. In shallow breathing can be there in this ILD, pursed lip breathing, the COPD. So we can diagnose these such cases with the good history and good examination.
Yes, fantastic. This was very, very concise and comprehensive. I haven't asked Dr. Mittal a question for a long time. So Dr. Ankit Mittal, I'm coming to you. Basically, please tell me what is the role of anti-pro-BNP, BNP in management or in a patient who comes with breathlessness? What would be the role of these parameters?
BNP and pro-BNP, as we know, are derived from the same precursor, that is pre-pro-BNP, which is cleaved in response to LV or any chamber, any four of the chambers, wall stretch, volume or pressure overload, pressure that lead to cleavage of polypeptide into BNP and pro-BNP. Out of two, BNP, basically B type natriuretic peptide called the natriuresis, it is an active form, whereas the anti-pro-BNP is actually the inactive form and have a more longer half-life of around 2 hours, whereas the BNP is a very short half-life of around 20 minutes only. So due to this difference, the levels of anti-pro-BNP are usually higher than the BNP. So whenever a patient coming to the ER with a shortness of breath, and we can go for a blood marker. It is readily available nowadays in the cardiac triage form in the casualty, and gives in hardly 15 to 20 minutes you can get a BNP value. So it can, if a BNP value is raised, then it can signify a pulmonary edema. The cutoff for that is more than 500. If BNP is more than 500 or anti-pro-BNP more than 1800, that indicates pulmonary edema. If the values are less than 100, value of BNP is less than 100, it signifies that cardiac cause is not there, and think of other causes of dyspnea. Similar value for the anti-pro-BNP is 300, less than 300 signifies rules out the cardiac cause as a dyspnea. However, the sensitivity and specificity is not that, but still it's around 80 to 90% sensitive as well as specific. Out of two, BNP is slightly more sensitive, specific than anti-pro-BNP, and anti-pro-BNP is more affected by the other parameters like renal dysfunction, atrial fibrillation, or age, BMI. They are more affected. They more affect the anti-pro-BNP, and that's why the value of anti-pro-BNP. Sometimes we have to factor in all these things also.
Okay, this was a superb answer that we were looking out for. That raise creatinine can actually falsely raise the levels of anti-pro-BNP.
Definitely.
Yes.
Definitely, ma'am.
Yes,
it affects dramatically to the anti-pro-BNP. Anti-pro-BNP does increase dramatically in response to increased creatinine levels. Given the age, older age values are not for anti-pro-BNP values are not standard values are not given.
Very well.
Also, if in a patient of renal dysfunction, if you go for a BNP, this cutoff, I told 100, this cutoff shifts towards 200 or 300. If you are dealing with a patient with renal function, if the patient is in acute kidney injury, then this value may be falsely elevated also.
Very good, excellent. So a very important point made by Dr. Ankit Mittal, that whenever the patient's creatinine is high, you cannot really look at the absolute values of BNP and anti-pro-BNP. If you have to ask for one of the two tests, it would be better to ask for BNP in a patient with high creatinine. Also, the values of anti-pro-BNP and BNP are higher for older people. Usually the labs do give us a reference range, but if your lab doesn't give, then please remember that for elders, the values are much, much higher. And I think also I want to say one more thing. What I want to say is that a patient who's in right heart failure will also have raised BNP and NT-proBNP, and therefore raised values doesn't necessarily say left heart failure. It can also mean right heart failure, and we as pulmonologists need to know this, because in right heart failure we don't need to give Lasix, whereas in left heart failure we must give Lasix. Do you want to add
one more?
Yes.
One more point. All the 4 chambers leads to increased value of this BNP. So even the atrial fibrillation, when LA is dilated, you may have an increased value of BNP. So in patient of atrial fibrillation, again we have to assess cautiously with the report.
Yes.
It is not so that's why this gray zone of 100 to 500 is there. In COPD, in other corpuscles, it usually doesn't cross more than 500.
Yes. So the thing is that I want to again repeat the same thing that I said, which Dr. Mittal pointed out very correctly, that the BNP and NT-proBNP are released by all the 4 chambers. So raised NT-proBNP or raised BNP does not necessarily mean left heart failure only. And for pulmonologists, a patient of COPD who's in right heart failure could very well come with high NT-proBNP. And if you are going to sit and treat him with Lasix, it's not going to be correct. You have to basically make sure that you correct the hypoxia and the hypercapnia, and if at all polycythemia that is there. So this is a very, very important point. The second point was about the high creatinine giving rise to falsely high values. I want people to know about this because these things are usually not mentioned in textbooks, and therefore we miss out, and therefore patients tend to get harmed because of this. And also elders have higher levels of BNP and NT-proBNP. The reason why we are doing this webinar is that we point out important things which are going to help us, improve our practice. So thank you so much, Dr. Mittal. Now I'd like to come to Dr. Abhamoni. Can there be any iatrogenic causes of shortness of breath in patients of endocrinology?
Yes, not many, but I'm going to list out the important ones.
Just the few which are important to pulmonologists,
Yes, so we are using beta blockers right and left. So beta blockers can exacerbate asthma. So always rule out a history of asthma in a patient in whom you are planning to give non-selective beta blockers like propranolol. Secondly, steroids. So steroids can lead to pulmonary embolism in at-risk patients. So if a patient like diabetic patients who is at increased risk of venous embolism, so in such patients giving very high dose of steroids, especially in the first month, the patients can precipitate with pulmonary embolism. So we have to be careful for that. And nowadays, like in gym and all, a lot of people are using anabolic steroids for bodybuilding. So this anabolic steroids excessive use can precipitate pulmonary embolism and can present with acute breathlessness. Also, oral contraceptive pills. If somebody is on oral contraceptive pills and that lady is at increased risk of thromboembolism, then definitely you should always monitor that patient, or you should opt for some other barrier contraceptions to that patient, perimenopausal or postmenopausal patients. So be careful while using oral contraceptives. One is zoledronic acid for osteoporosis is so much rampant. We are using zoledronic acid. So zoledronic acid or bisphosphonates injections can precipitate hypocalcemia, and as I have told, hypocalcemic laryngospasm. So always check vitamin D and whether the patient is normocalcemic before giving injections. And last but not the least, during surgery also a patient can present with pulmonary embolism and acute breathlessness. When does it happen? Any patient with increased risk of thromboembolism like Cushing syndrome and other etiologies, I would not mention all. So in such cases, a perioperative prophylaxis of heparin or anticoagulants is if given, then this will definitely prevent the thromboembolism in such patients.
Okay, so this was really very, very useful what you told us. I really liked what you told us, and great information. Thank you very, very much. We all know that in asthmatics, we don't want to use beta blockers, and so we have to be careful about it, take the history, and all the other things that Dr. Abhamoni said are going to be extremely useful to us. Now, I'd like to come to Dr. Virinchi. 2 quick questions to you. Basically anxiety, panic, etc. presenting as breathlessness is extremely fascinating, and we keep on coming across such patients. So basically, what is the management of such patients, anxious patients, panicky patients? They come to you with breathlessness repeatedly. So what is pharmacological treatment and what is non-pharmacological treatment?
Coming to the pharmacological treatment, I think most of the textbooks first talk about bringing in benzodiazepines and bringing in SSRIs. But now I would like to tell you all a few practical points about the pros and cons of bringing in these medicines, because a lot of times when we rule out a medical cause, we know that it is anxiety. We try to bring him on escitalopram or clonazepam. But the issue here is, one, when we look into the brain, like we spoke in the initial questions, we know that there is a reduced, a hypo-GABA state or a hyposerotonergic state. So undoubtedly, we need to work on the serotonin and the GABA. But now the most commonly used medicines like SSRIs have one disadvantage, that in the initial days, they worsen the anxiety. So a lot of times we bring in a 5 mg of escitalopram and the patient says that my anxiety has worsened. And the other issue is, when we start him on a benzodiazepine, he starts enjoying it and he never comes back to you because he likes to use it for ages together. And, he ends up, a year or 2 years later saying that, I was prescribed only 0.25 milligrams for 5 days by Dr. Nene, but I continued it for 5 years. And now that 0.25 has become 1.5 milligrams and I don't get the relief that I want. So that's the dependence. So a lot of times, I think it's very important that we need to be specific about informing them about the increased spike in anxiety that happens because of SSRIs. Undoubtedly, SSRIs and SNRIs are by far the most comfortable medications because of the reduced side effects compared to medicines like tricyclics. So escitalopram, sertraline, fluoxetine, venlafaxine, desvenlafaxine, these are the medicines, but again with caution. Coming to the non-pharmacological treatments, I think they play a very important role, and here the whole concept of CBT comes into play, the cognitive behavioral therapy. And a few concepts that each of you can actually tell your patients who have an underlying anxiety is activities like, one, JPMR. JPMR is Jacobson's Progressive Muscle Relaxation Techniques. It has 3 components. One, deep breathing. While you deep breathe, you contract and relax your each muscle group. And the third and the most important aspect is mindfulness. So here we are asking the person to deliberately stay in the present, because what is happening in anxiety is his brain is not in the present. His brain is constantly worrying about the future. And what is happening in depression is his brain is not in the present. It's constantly worrying about the past. I wish I should have done that. How am I going to do this? So these are the thought processes. So mindfulness is one activity where we deliberately help them stay in the present. So JPMR is one activity that, one, helps in reducing the anxiety as well as helps in calming down the excess activity of amygdala. And mindfulness activities is something that will help them improve their ability to stay in the present. Another activity is the 5-4-3-2-1 technique. So we ask the patient to use their sense organs to bring them back into the present. Like, I could be having a sudden thought about, oh my God, tomorrow is my result, or tomorrow is my assignment. And, my brain is, excessively thinking and I'm having an anxiety episode. At this point, I want to come back into the present. And for this, I use my sense organs. So what we tell them is, look at 5 things and start describing them. Touch 4 things, start describing them. Smell 3 things. Try to listen to 2 sounds in the present. Taste something edible. So what is how is this going to help? 1, distraction. 2, reassurance to the brain, because this is the bottom to top approach where the rest of your body is telling your brain, boss, I think you can calm down. You don't need to really panic. And the most important thing is mindfulness. Again, you're bringing the body into the present. So non-pharmacological techniques, you all can always Google, YouTube, JPMR and grounding techniques. Very helpful.
This was a wonderful answer. So whenever I have a patient who's anxious and very breathless all the time, I'm just going to give Dr. Virinchi's number to him, and I'm sure the patient will manage. I just want to say a very useful, quick tip, which I basically use, because the thing is that you need to treat the patient that time and they need to go back feeling more comfortable. So one of the tricks to know that the patient is anxious or panicking, and that is the reason the patient is experiencing breathlessness, is what happens is that these patients are hyperventilating because they feel they don't have enough oxygen. And as they hyperventilate, in addition to trying to get more oxygen, they cause carbon dioxide washout. And because there is carbon dioxide washout, they feel lightheaded. They feel there is tingling in their finger. Sometimes they feel the fingers are really turning the other way around, or they feel that they're actually going to pass out. So the patients who come like this, they are normally in the office and the colleagues get them that we don't know what happened, but he or she is extremely breathless and they are breathing like that with us. And at the same time, they are complaining of all these things. So when these things are done, saturation is fine, patient sugar is fine, the chest x-ray is okay, ECG is okay, and on examination, everything is okay. Before I get to do any other investigation, because they will take little more time, I tell the patient to take a deep breath. I tell them to hold the breath till I count 10, and then I make them breathe out through their mouth. Again, I make them breathe in through their nose. I make them hold the breath till they count 10. So while they are holding their breath and counting 10, the carbon dioxide which was getting washed out is allowed to rebuild. And as a result of that, that fear that something is happening, I'm going to fall down, which is going to make them breathe more and more and more, is going to go away. So I think a good thing to do is make them take a breath, let them hold on and breathe out. The other thing is, please give them a bag. This is what we used to do when we were students. We used to give them a bag and we used to tell them to keep on breathing into the bag. So you breathe in, you breathe out, the bag gets full of more and more carbon dioxide. So when you breathe in, you get more carbon dioxide, and if the carbon dioxide washout is going away. Third thing you can do in today's day and age, make them wear an N95 mask and let them keep on breathing. Because in N95 mask, we know we're going to keep on build up the carbon dioxide, and therefore they're going to breathe this. But this is something which I really want you all to know, that this should ideally be done, and the patient will automatically start feeling better without you doing anything, because the act of anxiety makes them hyperventilate, brings them into carbon dioxide washout, and this makes them hyperventilate again. And there is so much of fear. So you just do this simple thing in your OPD and the patient is going to go back actually happy. But of course, we will get every other test done to make sure it was not only anxiety. So great.
If I may just take 30 seconds, ma'am, after you do all of this, the patient will never come to me. But, like you said, what we usually do is, if, most of our patients bring the medicines in a polythene cover. So like you said, so I tell them, remove all those tablets and start, using that cover to breathe, like you said, and that's something that will immediately help them get the relief.
Wonderful. So actually, I have many questions which I have kept for you all, but the questions from the audience are just building up. So my plan is to just take some of the audience questions and then we can go back to my questions again. So we have Dr. Sampath from Andhra Pradesh, Vishakhapatnam, has asked a fantastic question. He is asking, how would you approach a patient who complains of grade 4 MRC SOB, normal saturations, but with increased respiratory rate and normal pulse rate? Let's see, Dr. Tarke, can you please take this question?
It's a difficult question. With the normal pulse rate and normal saturation, usually cardiac and respiratory patient may not present, because cardiac patient will have some bradycardia or some arrhythmia or tachycardia. Respiratory patient can have some other tachycardia, tachypnea, or the hypoxia will be there. But grade 4 dyspnea with normal saturation, normal vitals, except only increase tachypnea, maybe because of, I think, can be because of anxiety. This is one of the cause for that. And I think that should be my only differential in this scenario.
Wonderful. Dr. Sumit, would you like to add on something?
So I think maybe a history of any smoke inhalation, or I would say something if he's gone through any recent trauma or burns, or that could be one of the cause that also needs to be ruled out. If
wonderful. So I agree with both of you all. I have just one more contribution to make. The thing is that, every pulmonary embolism may not be fatal or lethal. But at the same time, even a small pulmonary embolism will make the patient hyperventilate, and there's a feeling of impending doom. If you all have read Crofton says pulmonary embolism, there's a feeling of impending doom. So there could be a small pulmonary embolism. The patient's saturations are fine. Patient's pulse also may be normal, but the patient is extremely restless. There's this uncomfortable feeling because of release of so many mediators. And as a result of that, there'll be a patient will be tachypneic. The saturations will be fine. The patient will complain of grade 4 dyspnea. So always think that there could be a small pulmonary embolism, which is not large enough to cause desaturation or tachycardia, but it's enough to offset the patient. And therefore, of course, the first thing we want to think about is anxiety, like Dr. Wadhwa and Dr. Tarke said. But please you make sure that this patient is made to undergo a D-dimer, and you want to check his potassium and calcium and magnesium. You want to check the patient's thyroid. You want to check the sugars, because anxiety, according to me, is a diagnosis of exclusion. You rule out everything and then you call it anxiety. Though Dr. Virinchi has been seeing patients who are 10% anxious, and I agree with him, but for us, we have to rule out everything before we call it anxiety and panic. So this was fantastic question by Dr. Sampath. I'd like to now go to a question by Dr. N. Prasanna Kumar from Kerala. He's asking, can thyroid storm cause acute onset breathlessness? Dr. Abhamoni, quick yes, no.
Yeah, definitely. So thyroid storm can present with breathlessness because thyroid storm can be associated with pulmonary edema. Thyroid storm can be associated with heart failure. So pulmonary edema, again, embolism also, it can happen, pulmonary embolism. So definitely thyroid definitely thyroid storm would have very high tachycardia, and the risk of arrhythmias is very, very high. So it is cardiac related and pulmonary related as well.
Wonderful. Now there's one question I'll ask Dr. Sumit Wadhwa to take. We have Dr. Madhav Kulkarni from Karnataka, Bangalore. He's asking, could anxiolytics help in any stage of management of dyspnea? So it may not be anxiety-related dyspnea. The patient could be having genuine dyspnea. Would anxiolytic help, and would it have a role? I think it's a very, very good question.
So anxiolytics would help, but then I would prefer ruling out other causes first and then taking up this matter if the all acute causes of dyspnea or any life-threatening causes of dyspnea are ruled out, and I have given my patient his vitals are stable, but then he still seems to be breathless and he still have increased respiratory rate, I would definitely try and use that anxiolytic, but as a last resort.
Wonderful. I think this was a very good answer. Actually, the thing is, we all know that in a patient of asthma, anxiety is known to trigger asthma. And if you keep on giving bronchodilators and giving the correct treatment of asthma, till anxiety is not gone, these people are not just going to settle down. So the important point over here is that find out the correct cause of breathlessness. Please treat that breathlessness. And if the patient is not a carbon dioxide retainer, if the patient is not a COPD who's in type 2 respiratory failure, if the patient is not a sleep apnea patient who's not using a CPAP and is trying to go to sleep, in these conditions, of course, in COPD, in CO2 retainers, in OSA patients who are not going to use CPAP, you want to avoid using anxiolytics, but in other conditions, even pulmonary embolism, you could use an anxiolytic. In pneumonia, you could use an anxiolytic. In pneumothorax also, you can use an anxiolytic provided you put in the chest tube. So I think this is a very, very good question. I really like it, and I totally agree with the answer that's given by Dr. Wadhwa. Yes, please, yes.
Miss, last 10 years, there are many studies. The long chronic lung disease such as COPD, ILD patients, lung cancer patients, almost most of the patients, they have the associated anxiety disorder. Because of their chronic disease status, they can develop the depression, anxiety. And definitely, along with the pharmacological management and everything, we should consider some anxiolytics or some antidepressant to such patients, especially after evaluation by the psychiatrist.
Wonderful. Now again, there's a question which I think maybe Dr. Abhamoni may be the best to answer, but anybody else can take it. Dr. Mittal can also take it. First opening to everybody and then maybe Dr. Abhamoni. So because she's going to give us a perfect answer. So we have Dr. Bandaru Raman Kumar from Andhra Pradesh, Ulluru. The question is, any hypervitaminosis or hypovitaminosis, can it cause breathlessness? And the other part too is, can hypothyroidism give rise to breathlessness? So this, Dr. Abhamoni has already told us that hypothyroidism could present with myxedema and it could give rise to this. But let's talk about hypovitaminosis, hypervitaminosis, and especially hypervitaminosis D. Dr. Mittal, would you like to take this first? Okay, anybody else wants to take, or it comes to Dr. Abhamoni because it's all about endocrinology? Okay, Dr. Abhamoni can reply, yes.
Yes, so hypovitaminosis as well as hypervitaminosis. So both can account with acute breathlessness or dyspnea, in other words. So I think endocrinology and this breathlessness is very closely related. So now vitamin D deficiency has been attributed to like pulmonary dysfunctions. Then vitamin D is attributed to increased pulmonary infections. Vitamin D deficiency is attributed to increased risk of asthma. So vitamin D deficiency, definitely there is an increased risk of various conditions, and which may ultimately, these lung conditions may lead to or present with dyspnea.
So
Then
sorry to stop. So I'm just clarifying, as Dr. Abhamoni rightly said, that vitamin D deficiency will predispose us to getting conditions, and those conditions will make us breathless, but vitamin D deficiency itself will not make us breathless. Is that correct?
correct.
I want everybody to understand this, because
but then again, in children, if the patient has vitamin D deficiency right from beginning, and the chest expansion is reduced because of the poor rib cage formation, bony deformity. Again, that is another one etiology that the patient can have reduced vital capacity.
No, correct. No, but I just want the correct message to go. That hypervitaminosis will predispose to a condition, and that condition, if present, will make the patient breathless. So hypervitaminosis per se does not cause breathlessness. That is the answer. What about hypervitaminosis D and any other hypervitaminosis? If not D, then any other vitamins?
So if the patient is hypervitaminosis D, so many of the time that patients are being given vitamin D supplementations for like 2 months as a treatment, but patient continue to take vitamin D at a high dose for maybe 1 year, 2 years. So ultimately, these patients will have vitamin D very high, that is hypervitaminosis D, which is equal to vitamin D levels of more than 100 nanogram per ml. So in such patients, they are at increased risk of hypercalcemia. They do have hypercalcemia, and ultimately this hypercalcemia can lead to lung dysfunction, fibrosis. So again, indirectly, vitamin D, hypervitaminosis D can come with dyspnea. Also, there is increased risk of arrhythmia because of hypervitaminosis D. So again, this indirectly will lead to dyspnea. Again, vitamin A is linked to lung functions, and it is said that vitamin A deficiency may alter the function of the lung and may lead to dyspnea in severe vitamin A deficiency. So vitamin D deficiency, vitamin A deficiency can indirectly present with dyspnea, and hypervitaminosis D will cause dyspnea by causing hypercalcemia.
Yeah, so hypervitamin, I want to talk about vitamin D because we all love to supplement our patients with vitamin D, and especially orthopedicians, they just give it left, right, and center, and it's 60,000 units they give once a week for probably 6 months to patients. So basically, please make sure that a patient who comes with breathlessness, you have to check the vitamin D levels, because vitamin D levels can give rise to hypercalcemia, and hypercalcemia will also give rise to breathlessness. So this was really interesting. I have a fantastic message by Dr. N.H. Krishna, CCI founder. So Dr. Krishna has put a message and he said that there are 885 logins at present and more are adding on. Brilliant webinar. He wants me to read out his message. So brilliant webinar, superb moderation, amazing panelists, congratulations, well done team CCI and team Cipla. He said if anybody reads this message, then he wanted me to read it out to everybody. So then this is very, very good. Great. Thank you, Dr. Krishna, for the compliments. It just keeps on making us go. There are many more questions from the audience, but I think I'll just quickly go to a few questions which I had actually planned about. So I would like to ask Dr. Mittal that what is the role of 2D echo and USG in the casualty? Quick.
2D echo we already know it's in the casualty. It is now available as a bedside tool in the casualty. Ultrasound machine is almost available in major centers. So we can go for a screening in the when a patient coming with dyspnea. So we can go for an echo screening immediately in the form of IVC, PA pressures. We can look for again diastolic dysfunction in the form of LV EDP we can measure, and then we can look for screen for renal wall motion abnormality or any ischemia that patient may be having, or maybe LV dysfunction, systolic dysfunction again patient may be having, that have to be ruled out. Also, in case of embolism, pulmonary embolism, massive or submassive embolism, if patient is having, then there will be acute dilatation of the RA and RV with borderline increase in pulmonary pressures. That can also indicate a likelihood of embolism. These are to be screened in the ER. And also we need to sometimes differentiate between the cardiogenic and non-cardiogenic pulmonary edema. If a HSXA is showing a bilateral opacity and we are not sure is it cardiogenic or it's ARDS, then echo can also differentiate that part. And about the USG test, it is again available bedside. Can be done in the ER. The presence of B line, there's a vertical shiny lines when we put a probe in the chest in the lower part. There's a vertical shiny line which increases with the and whose number increases with the severity also. So we can look for the presence of B line that can also help in identifying the presence of pulmonary edema or in the patient. Maybe cardiogenic, maybe non-cardiogenic. For that, we need to do echo and assess for the cause. And again, pneumothorax is not the cardiac part, but pneumothorax also in the ER can be identified with the help of ultrasound. And
very well said. I want to basically again insist and let everybody know that we as pulmonologists, we have to know how to do ultrasound chest. There is just no escape over here. We have to learn it because when the patient comes breathless to us, X-ray may take time, but ultrasound can be done there and then. It'll tell us about pneumonia, pleural effusion. It'll tell us about pneumothorax. And 2D echo also we just have to know because it'll tell us about diastolic dysfunction, the ejection fraction, about the valves. It'll tell us if the patient is in the state of shock because of probably the patient requires fluid from the IVC. It also tells us about pulmonary embolism from RA-RB dilatation. And therefore, every pulmonologist has to know how to do the 2D echo and how to do ultrasound of the chest. Dr. Tarke, can you tell me, in addition, what other investigations are immediately important, not later, but immediately you want to do them?
Immediately, as you said, ma'am, ECG followed by the X-ray, which should we can identify the pneumothorax, pneumonia, pulmonary edema, the common causes. Apart from X-ray and ECG, we can do the D-dimer, which can point toward the embolism, which can be the acute cause of dyspnea. And other thing in ECG, I can add something. For example, we can have apart from the acute coronary syndrome, we can diagnose the complete heart block, atrial fibrillation, atrial flutter, ventricular tachycardia, and some advanced tests also that we can do. Especially in the COVID time, we have seen the COVID test is negative, but patients are presenting the breathlessness. And if you do the CT chest screening, simple CT chest screening, we can diagnose the COVID-19 also well with the CT scan if the RT-PCR is negative. In addition to that, we can have the additional diagnosis of emphysema, bronchiectasis, and even if there is opaque hemothorax, it's difficult to judge on the X-ray. There is fluid or some solid tumor inside. We can get the ultrasound or CT scan done to rule out the tumor or the pleural effusion. And some advanced tests are also there available. So one of the audience has asked just now one question: how to differentiate between malingering and the actual breathlessness patient. Apart from the routine examination and history, we can do the certain tests like cardiopulmonary exercise testing, which evaluates different parameters such as VO2, that VCO2, anaerobic threshold, heart rate, ECG, BP, everything will monitor along with the respiratory rate, SpO2, ABG, lactate, dyspnea, leg fatigue. These multiple parameters are there. With that, I think we can differentiate fairly between the respiratory cause or cardiac cause or muscle deconditioning, or actually the patient is malingering. So this is the way so we can diagnose the cases faster.
Okay, so actually our dear friend Dr. Jaikishan Karaila from Haryana had asked this question: how to differentiate between a malingerer and real dyspneic patient. So honestly, the answer is that it's actually very, very difficult because a person is malingering and therefore he's exactly know how to fool us, and malingerers probably do more study than even us. So believe me, to differentiate a malingerer from a true breathless patient is almost impossible, and we just hope and pray that we don't get such patients coming to us. I'd like to ask this question to Dr. Wadhwa. We have a lovely question from Dr. Swati Chauhan, Maharashtra, Pune. We know her, a lovely pulmonologist. So Dr. Swati is asking how to practically differentiate between cardiogenic pulmonary edema, bronchopneumonia, and ARDS at point of care in casualty. A fantastic question. Dr. Wadhwa, please answer.
Yes. So basically, cardiogenic pulmonary edema means that the patient has a known cardiac cause or he has landed up in heart failure, and we will have on examination also we'll have patients have raised JVP, swelling in the limbs, increased breathlessness, any chest pain or profuse diaphoresis, and plus his extremities would be cold because of the low cardiac output. While patients with bronchopneumonia may have fever, ARDS is also related to infection, and other smoke inhalation causes of severe sepsis we have fever as a cause, along with cough and sputum, chest pain, and they may have the extremities would be warm to touch. And they won't be less chances of having a pulmonary edema or fluid overload state. So this can be judged on the examination of the patient. Plus, we would go to the past history or in recent past history of any fever, cough with expectoration, any recent history of illness, or any past history. In investigations, we can go to the ECG or point of care ultrasound and X-ray, which would guide us better for further examination, for further management.
Yeah, very well said. Just kind of summing up which Dr. Wadhwa said, if it is pneumonia, then usually the patient will have history of fever with chills. Patient could be having purulent sputum, and usually history of pleuritic chest pain is present, and the history is usually acute. If it's pulmonary edema, then often frothy pink sputum actually comes out. Patient could be having edema feet. There'll be an S3 gallop, which we really forget to auscultate for, So S3 gallop is something very, very important. It's like horses galloping, and you can actually make out if it's present. And ARDS is basically PO2 for FiO2 ratio. So you will need an ABG to diagnose it, but pneumonia can also present as an ARDS. So this was very, very important. And I would basically say that if you know how to get an ultrasound done of the chest, and if you have a 2D echo with you, then you can actually differentiate the three conditions upfront. Would you all agree with me?
Yes,
Yeah.
sure.
Yeah, so the bottom line is that all the younger chest physicians, you all have no choice. You all have to, just like you all learn interventions, you all have to learn ultrasound, chest, and 2D echo. That is absolutely a must. We have a wonderful message from Dr. S. Jayaraman, a dear friend from Tamil Nadu, Chennai. He's saying wonderful discussion. Thank you, team CCI. So I have absolutely the same to echo. Actually, our time is up. There are many, many questions still coming. So I would just like to ask, should we continue or should we just stop? It's 9:30, so... Okay, fine.
One or two questions you can take, ma'am.
Sure. So I think I just recently asked question to Dr. Wadhwa, Dr. Mittal, and to Dr. Tarke. So let me go back to Dr. Virinchi and Dr. Abhamoni. I think I'll ask them questions and I'll kind of stop. So more than asking a question, do you want to contribute something? In what way can we help patients who are coming to us for sudden breathlessness, and what can be done by us in our room? Can you tell us, or anything interesting that you want to tell about your patient? Any example you'd like to give, Dr. Virinchi?
Well, ma'am, because there was a question about malingering and
Yes,
real dyspnea.
This
So,
question sorry. Yes, please answer this question. Yes.
I'll just give a very interesting case. So this was a 35-year-old female who was a divorcee and had severe asthma when she was a child. So she came to the hospital with some jerky movements. And then what she said was, after these jerky movements, she started developing a lot of weakness, because of which she had inability to walk. And during these episodes, she was having very clear consciousness. After the episode also, there was a clear consciousness. And post the jerky movement episode, she would say that, there was a difficulty in breathing. So there was the gagging and, the difficulty in breathing. And then, the pulmonological physician, neurologist, all the interventions were done. And that is when we as psychiatrists were called. After detailed history, because, I remember in the initial questions, Dr. Chandrakant sir was talking about how history taking makes an important role. So long story short, after a detailed history, what we understood was, one, these, symptoms started off because in that month, 5 years back, she had lost her child. So that was something triggered these symptoms right now. So that was one, talking about the jerky movements that started. And talking about her asthma symptoms, that difficulty in breathing symptoms, what she clearly explained was, when she was a child, every time she had difficulty to breathe, she had doctors surrounding her, taking care of her, which she was missing right now in her grief. She didn't have people around her, taking care of her, talking to her, because it's been 5 years now that she's lost a child. So the cry from within is making her behave this. Is this a malingering? No, this is a dissociative disorder, because she's not anxious about all of these happening, but when these happen, she does not know how to control. So one, dissociative disorders is something that we commonly see because malingering is something where the person is doing intentionally. They don't want to go to college or they've not finished their homeworks, but there is this one entity before the malingering is diagnosed, that is the dissociative, where they do not know why it is happening, but it is happening. So I think this is the mystery and beauty of psychiatry, what we enjoy. And I think, before I end, all I would like to say is, non-pharmacological measures of anxiety are much better than the pharmacological methods, because medicines like SSRIs, like we discussed, do trigger. But again, with the whole COVID, the whole pandemic, we've seen a lot of increase in people coming with the anxiety spectrum. So I think if there are young physicians, you are going to see equal number of anxiety as well as asthma patients. So you should be geared up, is all I can say in the audiences.
This is very, very nice what you liked. Even I think from actually the thing is that, a malingerer will be really a smart fellow, whereas a person who's doing it dissociatively is going to be presenting the way they feel they are supposed to present.
True,
So their way of showing a convulsion or their way of showing breathlessness is what they have read in a book or what they have seen in a textbook, but it's not, I've seen in a movie, but it's not like what we have studied and experienced. So this is a very, very good thing. It can actually let us even know who to be careful about, because a malingerer is somebody we want to really be careful about, and please refer them to our colleague and make sure they don't come back to us. But if it's somebody who's having dissociative factors, we basically want to be really sympathetic towards them, and we want to try our best to help them, and we want to send them all to Dr. Virinchi. Okay, so now I'd like to come to Dr. Abha. Dr. Abha, I'm sorry, Dr. Abhamoni, but I'm happy to call you Dr. Abha if you don't mind. So,
yeah, sure.
Yes. So, Dr. Abha, I learned a lot of things today from you, and I was very, very happy to know about, a lot of things that you told us. So, do you want to tell us about something that we should really look out for, or anything that you would like to tell us, please?
Yes, definitely. One thing, both as endocrinologist and you as pulmonologist should remember about vaccination. So, a lot of diabetic patients will come to you with lot of problems, with lot of acute breathlessness. But when we call them for follow-up, or when we are treating these patients, we should always emphasize them regarding the vaccinations, about pneumococcal vaccinations, influenza vaccinations, flu vaccinations, and of recently COVID vaccinations. Because we know that these diabetic patients, they have increased risk of infections, like not only bacterial, also fungal as well as viral. And as you have seen during the COVID pandemic, these diabetic patients were the patients who had suffered the most. The rate of complications, the rate of respiratory failure was much, almost 6 times higher in diabetic patients. So we should always emphasize that take your vaccinations, and annually they have to take regular vaccinations, flu vaccinations, and that has to be emphasized. And a proper lifestyle modification and exercise, and definitely the spirometry exercise that they keep on doing. Like a lot of pulmonologists, they keep on telling the diabetic with obesity that you have to improve your lifestyle, because many a time diabetic with obesity increase the risk of or predisposed to asthma and COPD. So again, we have to emphasize them about the lifestyle modifications and also annually checkup. So I think this is very, very important, and regular follow-up, prompt diagnosis and referral to a specialist would definitely reduce this acute breathlessness due to various complications of diabetes.
Very well. I was a part of the ICS NCCP guidelines on vaccinations, and therefore anybody who promotes vaccinations, I'm very, very happy with them. And Dr. Abha has really told us that we have to make sure we encourage our patients for vaccinations, because that is really going to reduce their visits to casualty with acute breathlessness. We want them to come to us, but we don't want them to come acutely, because it actually spoils our sleep and spoils our clinic timings. So vaccination is very, very important. We have a wonderful comment from Dr. Vijendra Pal Singh from Haryana, Faridabad. Dr. Vijendra Pal Singh is saying, thank you for a wonderful discussion, but please take some more questions. I feel that good things should be stopped on time, and we should not really drag them till people get tired. But quickly, 2 questions just to respect Dr. Vijendra Pal Singh for this wonderful comment. I'll come to Dr. Sumit. Dr. Sumit, please tell me, because how can we diagnose methemoglobinemia, and quick, how to treat it? Because these patients can come with acute breathlessness.
Yes, surely. So let me have this. So we had one of the patients who is an elderly diabetic hypertensive, and he presented us with shortness of breath and some chest pains which started since few days. and he's been taking telmisartan, metformin, and on examination, what we found out was that he also has some lichenoid dermatitis for which he used to take dapsone. But then in presentation on the emergency room, he had an oxygen saturation of 84%, and which even did not improve after giving 10 liters of oxygen. So that qualifies as a refractory hypoxemia, but otherwise his pulse rate was normal and he was afebrile. So on examination also, we could note that he has a little central cyanosis. So, but when we did the ABG, his PaO2 was normal, and this is known as a saturation gap. So if it is more than 5%, it is indicative that he may have a history of methemoglobinemia. So there are two varieties. There is a congenital one and the acquired one. So acquired one is mainly drug related. So in his case, that it was due to dapsone. Other causes may be nitrate drugs or NTG, aniline, pyridium. So the patients taking this are more prone to develop methemoglobinemia. And basically, presence of methemoglobin more than 30 to 50%, if it is the concentration is there, the patients mainly have tachypnea or fatigue. But then severe methemoglobinemia with more than 70% may even result in hypoxemia and death. And the treatment is basically symptomatic based on the severity of presentation. We have to remove the offending medication and give him supplemental oxygen in severe cases, maintain intravenous rehydration, and cardiopulmonary support should be required if it is more than 30%. IV methylene blue can be used in a dose of 2 grams per, and in severe cases you may require exchange transfusion with hyperbaric oxygen.
Okay, wonderful. Thank you so much. I want to just basically give an example of one patient. One patient was a very nice lady in a high-profile party. She had no problems at all. She had history of asthma as a child, but she was doing quite well. Normally, she would never drink, but she went for this party and people told her to have a drink. She had a drink. She felt very breathless and she came to us. So basically, she had red wine. So just to let everybody know that red wine is a trigger for asthma. And if your patient is an asthmatic, please tell them from before not to have red wine, because even a sip of red wine can actually cause release of mediators, which can give rise to severe attack of asthma. And Dr. Mittal, being a cardiologist, might be telling his patients that normally don't drink, but you have to drink, then have red wine, because red wine is good for the heart. But we as pulmonologists will be, of course, don't drink. But if you have to only drink, then let it be anything. If you are an asthmatic, let it be anything else but red wine or white wine or champagne, because all this contains wine, which can trigger an attack of asthma. So I would like to end this discussion. I think it's been a fantastic discussion. Every panelist of mine, Dr. Tarke, Dr. Wadhwa, Dr. Virinchi, Dr. Abha, and Dr. Ankit Mittal have given us so much of information. They have really been spot on. We've had wonderful audience who've been asking questions, writing great congratulating messages. And thank you very much. I've really enjoyed doing this webinar. And a huge big thanks to all my panelists and team CCI, Dr. Krishna, Dr. Chennam Chetty, Dr. Atri, Dr. Ravi Dosi, and Dr. Narender for inviting us to do this webinar today. Thank you very much.
Thank you, Nene ma'am, for moderating the session so well.
No, thank you. I mean, you all were so good. I've learned so much from each of you. Thank you so much.
Thank you. Thank you, everyone.
Thank you.